Good morning, good afternoon, or good evening, depending on where you're joining us from. Welcome to the third edition of the Caribbean Antimicrobial Stewardship Conference. We are so glad to have so many of you joining us from your offices, your labs, your hospitals, and whether you are connected by yourself or if you are following this seminar with other colleagues, thank you for investing this time in the fight against infectious disease. I want to thank the wonderful team of people who have worked and continue to work tirelessly behind the scenes to put this conference together in this new format. A special and heartfelt thank you goes out to all our speakers for their willingness to take the time to share and interact with us today on various topics. A sincere thank you goes out to our sponsors, for it is in this collaboration between industry and the front lines that we are able to leverage resources towards common goals. Lastly, thank you for being an engaged and active participant today. The Caribbean Antimicrobial Stewardship Conference is hosted by Lab Knowledge and is made possible by contributions from various sponsors. Lab Knowledge is an institute for continuing education and research in laboratory science and is fully funded by Pharminpex. 4 years ago, in a year-end debriefing following our travels throughout the Caribbean, I shared with my team the observation that there are a lot of good efforts going on in the Caribbean, specifically in the area of infectious diseases, antimicrobial stewardship, and infection prevention and control. But that unfortunately, there were not many avenues for this information to be exchanged among the countries and institutions of the Caribbean, and most importantly, between lab techs and medical practitioners themselves. I also noticed a real interest from all organizations to engage in continuing education and a commitment to fight infectious disease despite the lack of resources. These observations gave rise to the establishment of the Caribbean Antimicrobial Stewardship Platform, a lab knowledge initiative in which the focus was to create an avenue for sharing knowledge, practical experiences, and best practices, promote collaboration between islands, organizations, and individuals in the fight against infectious disease, and provide the infrastructure to link not only global, but especially our local Caribbean experts and make continuing education initiatives more accessible. In 2017, thanks to a funding guarantee by Pharminpex, Lab Knowledge committed to a 5-year cycle to host the Caribbean Antimicrobial Stewardship Conference. The first conference was held in Curaçao in September of 2018 in collaboration with NASCO, the Dutch Caribbean Foundation for Higher Clinical Education. In October of 2019, the conference was held in Barbados in collaboration with Dr. Corey Ford and his team from Caribbean Infection Prevention and Control. This year, the conference goes online and is spread over 3 consecutive monthly live webinars covering the topics of sepsis, infection prevention and control, and antimicrobial stewardship. Last year in Barbados, I was very much inspired by the breadth of medical professionals from all areas of healthcare who felt the importance to engage in infection prevention and control. It led me to declare in my opening statement that together, we can create a world in which there are no more deaths from infectious disease. While this may seem like a bold statement, and while it may be true that the results may not come overnight, this vision of our future is still worthwhile. In a year where we face the challenges of coronavirus, it may be easy to feel overwhelmed or feel like this problem is too big to solve. Still, there is a lot to celebrate. I want to remind each and every one of you that you are an important piece of the puzzle. As a healthcare practitioner, your choices directly impact the lives of people in your community. Most of these people don't know you, or most of these people may not comprehend the role you played in their health and well-being. You may not receive the recognition you feel you deserve. Despite all this, choose to make a positive impact and choose to make a difference in the fight against infectious disease. We may or may not be the generation that will eradicate death from infectious disease. But if we all do what is within our reach to contribute, we will be the generation who made significant progress on this issue so the next generation can get a head start. And that is certainly worth celebrating. Enjoy the conference and above all, share, interact, learn, and commit to the action that is within your reach to create a world in which there are no more deaths by infectious disease. Thank you.
Thank you, Mrs. Neila Diaz, and a good morning to all our participants to this webinar. Yesterday, 18th of November, marks the start of the Antibiotic Awareness Week. This one-week observance happens annually and is an opportunity to raise awareness of the importance of appropriate antibiotic use. Antimicrobial resistance has become a global challenge, and a successful solution will require global cooperation. During this 2 days webinar mini-series, we will go more in depth about topics regarding antibiotic resistance. This webinar is sponsored by Lab Knowledge Foundation, Pharmapex NV, and BioMarieux. My name is Emelie Martijn. My profession is clinical biochemist, and most of you know me as the conference coordinator of the COSP conferences for the last 3 years. Today, I will be the moderator. I would like to give a special welcome to our friends from Jamaica, Suriname, Bonaire, Guyana, St. Lucia, Trinidad and Tobago, Chile, Colombia, and Curacao. A warm welcome to you all. I would like to remember you that you can type your question in the chat box on the right hand of your screen. After the presentation, I will ask our speaker your questions on your behalf. And now it is my pleasure to introduce to you our lecturer of today, Dr. Norma Hernández. Dr. Norma Hernández Guerrero graduated in general medicine from De La Salle University School of Medicine in Mexico City. She graduates as a specialist in internal medicine at the Hospital Español de Mexico, also in Mexico City. She obtained her subspecialism in infectious diseases at Hospital Fray Antonio Alcalde de Guadalajara, University of Guadalajara. She has experience as a coordinator of the Epidemiology Surveillance Committee and the Program for Automation of Antibiotics in Latin America, PROA. This stands for Programa para Optimización de Uso de Antibiótica en Latinoamérica. She has 12 years of clinical experience in the management of patients with infectious diseases in different hospitals in Guadalajara. For example, Hospital Ángeles del Carmen, Hospital Real San Jose, Hospital San Javier. She is sub-researcher at the University of Texas, based in Guadalajara. She is a physician assigned to Hospital Ángeles Acospa, and she is the BioMarieux Medical Director for Latin America. Please join me to give a warm welcome to Dr. Norma Hernández. Dr. Norma, the floor is yours.
Thank you so much, Emelie, and thank you to all the organizers and to all the people who is here in these difficult times. I'm going to share my screen. So can you just confirm that that you can see my screen and that you can hear me well?
Yes, we can.
Okay, perfect. Thank you very much. So, well, again, good morning to everyone and thank you for being here. And I am going to share with you the topic today about the importance of timely diagnosis and surveillance of antimicrobial resistance and antimicrobial stewardship program. And I want to start with one of my favorite phrases or sentence. And I think it's the initial or the birth of the antimicrobial stewardship. And this phrase said the next thing. The microbes are educated to resist penicillin, and a host of penicillin-fast organisms is bred out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to infection with a penicillin-resistant organism. I hope this evil can be averted. So this phrase was dictated from Alexander Fleming. You know, Alexander Fleming discovered the penicillin, and he was interviewed in the New York Times in 1945, and he said this. Of course, for 1945, we already have resistance in Staph aureus to penicillin. So right now, this sentence is really important because right now we not only have resistance to penicillin, we also have resistance to all the antibiotics that we have. So it's really important, as Nela mentioned, that we together fight against the antimicrobial resistance, and that together we preserve the antimicrobials. For this WAAW week, the sentence from the World Health Organization is united to preserve antimicrobials. So I think this is very important because with COVID, we have a lot of use of antibiotics again, and we are having back in our advance to all these actions to preserve antibiotics. So I'm going to start with the first pool, and if you can share the first pool, please. I have a question for you. We are going to have 3 questions for you in these sessions, and the first question, and I'm going to stop to share my screen, otherwise I can see the pool. So the first pool will be, and can you put me the pool? Do you have any antimicrobial stewardship program in your hospital? Four seconds. It's a really simple question, and I'm going to end the poll and see the results. And what we can see is that the most of the people doesn't have antimicrobial stewardship in their hospital. And I think that's really important to mention, because right now we should push in all our hospitals to have this kind of antimicrobial stewardship programs. I'm going to go to a clinical case. I always like to share clinical cases with you because I think we all dedicate to health because of the patients. I mean, we are working here because of the patients. So this is a clinical case that we have 3 weeks ago. It's a male patient, 47 years old, and he was admitted to the hospital with shortness of breath, cough, and fever. He had medical history of high blood pressure and diabetes mellitus type 2. He was admitted directly to the ICU because of acute distress respiratory syndrome, and he got diagnostic of COVID-19 with a PCR. They started in the hospital with ceftriaxone. No cultures were taken since the admission, and no cultures were taken during all his admittance in the ICU. And 10 days after in the ICU, he had a new onset of fever, a septic shock clinical presentation, had blood cells count, and new chest infiltrates in the X-ray. And you can see the X-ray. You can see that the patient had consolidation areas in both of the lungs, imagining of a SARS-CoV-2, but also a new onset of pneumonia. So the patient had the diagnostic of acquired ventilation pneumonia, and cultures were taken. Remember, this is a patient that is really ill, that has septic shock, so we need to start the empiric antibiotic therapy as soon as possible, otherwise the patient is going to die. So I'm going to go to the second pool, and I would like to know which kind of antibiotics will you start to this patient. So here at the right, you can see the pool, and the question for you is, what would be the appropriate empirical therapy for this patient. Here you have here many options, so you can go to pool and vote for one of these options that you have here. We have the first option is piperacillin tazobactam plus vancomycin, or meropenem plus vancomycin, or meropenem plus colistin, meropenem plus colistin plus vancomycin, and I will give you a couple of seconds to think the answer. I'm going to talk about these options that we have here for starting to do. Okay, I'm going to end the poll. And as you can see here, the answers were, okay. Well, the most of the people vote for the combination of meropenem, colistin, and vancomycin. Let me go back to the presentation, and we are going to discuss about the options. Remember, for this kind of patients, there is not a correct answer or an exactly answer, because the answer that you, or the antibiotic that you are going to choose to treat this kind of patients will depend on the epidemiology that you have in every of your hospitals. So it's really important that you know the prevalence of the most important microorganisms that are causing ventilator-acquired pneumonia in your hospitals. And you will have to know the patterns of resistance and susceptibility of your microorganisms, because otherwise you are not going to be able to start a very good empiric therapy with antibiotics. For example, for my hospital, I can tell you that the most prevalent of microorganisms are Pseudomonas aeruginosa and Acinetobacter baumannii. So my first choice for this kind of patient will be meropenem plus colistin, meropenem in high dose plus colistin. The combination of meropenem, colistin, and maybe vancomycin, because you suspect that you already have an Staph aureus methicillin resistant, it's really nephrotoxic, and you will have to choose between these options and think in the adverse events that can be produced with that combination. So it's really important that you choose the antibiotics in order of your epidemiological data. So every hospital, the first that they need to have a very good antimicrobial stewardship program is surveillance data. So epidemiological data of prevalence of microorganisms in every of your wards or in every setting, especially in the ICU or the critical areas, for example, surgery, for example, internal medicine or nephrology, because otherwise you are not going to be able to choose the best option of empiric therapy for this kind of patient. Don't forget the patient. We are going to come back to the patient in a few slides. So, before 1940s, before Alexander Fleming discovered penicillin, we were living in the pre-antibiotic era, and the infectious diseases were the first cause of mortality. The patients died from pneumonia, tuberculosis, typhoid fever, neonatal mortality. Then the antibiotics came to our world, but now, unfortunately, we are living the post-antibiotic era, and now the patients are still dying of pneumonia. Pneumonias that are resistant with microorganisms resistance, like Staph aureus methicillin resistant, or E. coli, we produce extended spectrum beta-lactamases, tuberculosis, gonococcal, and sometimes we have people dying from salmonella, for example, when they become from countries where they have high rates of multi-drug resistance of this kind of bacteria. So it's a moment to do a reflection, and of course, which is the problem of all this antimicrobial resistance? The overuse and the misuse of antibiotics in humans and animals. We don't have very good options coming about antibiotics. The antibiotic pipeline is dying. Transmission of drug-resistant organisms and antibiotics in the environment. The problem here is that if we don't have any stop of the antimicrobial resistance, a return to a pre-antibiotic era could see 40% of people dying from infections. Remember, right now we have transplant patients, we have patients, oncology patients, that they receive chemotherapy, or maybe a surgery patient that gets infection in the hospital with this of microorganisms, multi-drug resistant. They won't have any choice to survive, even they survive to other complications. So it's a global crisis. Here you have a lot of headlines or header about this problem. Some of them calling an apocalypse problem. And right now is the worst threat that we have in the 21st century. The estimated deaths for 2050 will be 10 million cases per year if we don't stop the antimicrobial resistance. A silent tsunami, some of them. You can see antimicrobial resistance is not just a global threat. It is a reality that can affect all of us, has a potential to rewind decades of progress in modern medicine. So that's important of the antimicrobial resistance. And here is a very interesting study that was published in the Lancet, because it's not only the deaths that the antimicrobial resistance produce. We know right now that every 45 seconds, one person dies because of an infection that can be treated with the antibiotics that we have right now. It's also the disability that this kind of infections may produce in the persons. And of course, the persons cannot go to work, and the cost of this kind of infection is really high. In this study, you can see that right now the most important problems is Klebsiella pneumoniae or E. coli, resistant to third generation cephalosporin, or also Klebsiella pneumoniae, Acinetobacter, and Pseudomonas aeruginosa, producer of carbapenemasa, also Staphylococcus resistant, and vancomycin with resistance to, Enterococcus fecalis or Enterococcus faecium resistant to vancomycin. So we have a real problem, and we need to take care of this problem. This O'Neill study, and maybe all of you have heard about this Lord Jim O'Neill. Lord Jim O'Neill is a financial guy that is in charge of the global action to fight the resistance. They choose a financial guy because it's really important to have a transversal and people working together, scientific, governments, agriculture, and all these kind of people working together to fight the resistance. The study where they predicted that for 2015 we are going to have 10 million death cases per year if we don't stop the antimicrobial resistance, and this is really important. Remember that in 2009, the World Health Organization priority the list of the microorganisms that needed new antibiotics. Of course, the priority number one is Acinetobacter baumannii, and unfortunately, we don't have many options to treat Acinetobacter baumannii multi-drug resistant. Actually, the only new antibiotic that is coming for Acinetobacter baumannii will be cefiderocol, and actually, we have already resistance from Acinetobacter baumannii to cefiderocol that it has been launched a few months ago. Actually, we don't have it yet in Latin America, so really important to point to Acinetobacter baumannii. The other ones are Pseudomonas aeruginosa and Enterobacteriaceae producing of carbapenem, and extended spectrum beta-lactamase. And other bacteria that you can see here are also a problem, and we really need to focus on this kind of bacteria because most of them produce viral hospital infection. And why is this important? If you can see here in this study, the mortality with microorganisms that is resistant is the double when you have a resistant microorganism versus a susceptible microorganisms. This is a study where the infection with the Staphylococcus methicillin sensitive was 11.5% versus an infection with penicillin-resistant Staph aureus that the mortality rate was 24%. And also the cost, you can see here that the cost duplicates when you have a resistant infection. And also, it's not only the mortality, of course, the length of the stay is high because we need to do more treatments and more studies to this kind of patients. So you can see here that there are several infections with multi-drug resistant microorganisms, and you can see that in all of them, the length of stay duplicates, or of course, with more cost or additional cost, and the mortality. Look here, the mortality with an Enterobacteria resistant infection versus not infection. So it's really important to have this in our mind. So we understand the mechanisms and the drivers on antimicrobial resistance. We are going to do something about it. Remember, the most important determinant for antimicrobial resistance is the animal antimicrobial misuse or overuse. We are using in agriculture and in the animals these antibiotics that then the meat or the food goes to the human and consume this food contaminated, or well, not contaminated, but with antibiotics that then are going to produce our microbiota, resistance. So it's really important for us to take action not in human misuse or overuse, also in animal misuse or overuse of the antimicrobial agents. And another thing that is really important, and they point in this study, is the suboptimal rapid diagnosis. Fortunately, in many of our institutions or in our hospitals in many of our countries, we are not having good diagnostic techniques, and the microbiology lab that is really important to support all the antimicrobial stewardship sometimes doesn't work as they should, or sometimes the physicians are not aware of how to interpret, for example, antibiograms or interpret some results of tests like a PCR multiplex or spectrometry mass. So it's really important for all the hospitals to have medical education in order to prescribe better the antimicrobials and to have their rapid diagnostic test that supports an antimicrobial stewardship. So this is the rule of the 30s. And why do we have this antimicrobial resistance? And this is really important because those are antimicrobial prescribing facts. This is a study from the CDC. And what they say is that 30% of all hospital patients at any given time receive antibiotics at least one dose. Over 30% of antibiotics are prescribed inappropriately in the community. Up to 30% of all surgical prophylaxis are inappropriate. 30% of hospital pharmacy costs are due to antimicrobial use. 10 to 30% of pharmacy costs can be saved by an antimicrobial stewardship program. So all this data is really important because 30% of prescribed antibiotics are not necessary. And in the primary care, that is also another important problem where we have abuse of the antibiotics is, and you can see in this study, more than 50% of prescriptions for respiratory tract infections are inappropriate. Remember, respiratory tract infections are caused by virus, but a lot of them receive an antibiotic. And I can tell you right now that with patients with COVID-19, 90% of the patients are receiving an antibiotic. We know that more or less only 20% of the patients are bacterial co-infection. So it's really important to us to think about this. What happened in the hospitals? We have also misuse or overuse of antibiotics in the hospitals. 30 to 50% in the hospitals, the prescription was inappropriate or suboptimal. Especially the most important is that antimicrobial was not indicated. Maybe we use a run spectrum or a broad spectrum antibiotic. Incorrect duration, incorrect dose, microbiology mismatch means that even we have a result from the microbiology lab, we don't do the adjustment to the antibiotic when we have the result. Or a spectrum too narrow. So all of these are the problems that we have in the hospitals when we prescribe antibiotics. This is a study about the impact of inappropriate initial antibiotic therapy. It's a meta-analysis, and you can see that are 60 publications. And inappropriate antibiotic therapy was associated with more than threefold or increased risk of mortality in septic patients. Gram-negative study is a systematic review study, but it's really important that we have this threefold of increased mortality because we usually don't start the appropriate initial antibiotic therapy or the empiric antibiotic is wrong. So the fight against AMR, and this is Lord Jim O'Neill, and in this publication that they have tackling antimicrobial resistance of 10 fronts, you can see all the actions that we need to do globally to fight against the antimicrobial resistance. You can see that the most important, and usually they ask in all the interviews to Jim O'Neill, which is the most important, and he answered that diagnostics are the single biggest potential game changer in the fight against antimicrobial resistance. So again, rapid diagnostics is the best for fight the antimicrobial resistance. Here is the principles of antimicrobial prescribing, and everybody thinks that prescribing an antibiotic is really easy. Actually, now we know that we need to learn in the school medicine how to prescribe antimicrobial agents because actually it's really hard. Usually in the school medicines, they don't teach us about microbiology or about how to prescribe antibiotics. So globally is pushing topic, and we invite all the universities to join to these to help the students to prescribe better antimicrobial resistance and to have courses or lectures about this topic. So, of course, we need the medical history and all the medical findings, very good physics exploration, the microbiology to know which is the bacteria or the virus or parasite or fungus that is causing the infection. It's really important to obtain culture before first antimicrobial dose. And remember, in the Surviving Sepsis campaign, the most important when you have a patient with sepsis or a septic shock is to take blood cultures in the first hour and to prescribe antibiotics in the first hour. So really important, the cultures and the antimicrobials prescribing in the first hour. Also, you need to know about pharmacokinetic and pharmacodynamic of all the antibiotics. Where is the infection? The site of infection is really important. And of course, to have a review after 24 or 48 hours that you started an antibiotic, especially when you start a broad spectrum antibiotic. So what physicians can do to fight antimicrobial resistance? Use a diagnostics before treating, prescribe antibiotics only for bacterial infections, and improve the use of antibiotics that still work. So that's antimicrobial stewardship. And antimicrobial stewardship is right now defined as the right indication, the right dose and rule, right duration, less harm to the patient, and the right antibiotic. That is our main goal when we do a prescription of antibiotics. And of course, educate the patients about antibiotic resistance. You have patients in your office and the patient is only with that infection of respiratory tract, superior infection. You have to explain that they don't need antibiotics, that they are going to be safe without any antibiotics. So the patient is not going to ask antibiotics. We have here in Mexico a very bad problem about that, and the patients arrive to the office requiring an antibiotic. So it's really important to have this education to the patient. And this is a really important thing. We are talking right now about antimicrobial stewardship, but we also have to talk about diagnostics stewardship. So, as we said, antimicrobial stewardship, right interpretation, right antimicrobial in the right time. Diagnostic stewardship is the right test to the right patient at the right time. Because with the right diagnostic, we are going to do a better antimicrobial stewardship, so the patient is going to have a better outcome or a better clinical evolution, and probably will be out of the hospital faster than if we don't use diagnostic tests. So this is a very good publication. I love it actually, because it talks about how many times or the moments that we have to have before we prescribe antibiotics or when we prescribe antibiotics. So the title is Rethinking How Antibiotics I Prescribe, incorporated the 4 moments of antibiotic decision making into clinical practice. So the first moment is when the patient arrives, and the first moment that I have contact with the patient. First question that I have to make to myself is, does this patient have an infection that requires antibiotic? The second one is, have I ordered appropriate cultures before starting antibiotics? What empirical antibiotic therapy should I initiate? The third one, a day or more has passed. Can I stop the antibiotics? Can I narrow the therapy? Can I switch from intravenous to oral therapy? The fourth one, what duration of antibiotic therapy is needed for patients diagnosed? Remember that right now in infectious diseases, they are using less more, because actually we used to treat the patient with a lot of days of antibiotics. Right now, we are trying to narrow the days that we use antibiotics. For example, for a pneumonia, community-acquired pneumonia, we are prescribing antibiotics maybe for 5 days if the patient is going better. And the use of biomarkers like procalcitonin will help us to stop antibiotics before or sooner. So it's really important to have these 4 moments every time that I make rounds with a patient, every time that I see a patient with an antibiotic. How well do we do when we prescribe empirical antibiotic therapy? And a study from the United States, it includes 6 US hospitals. And what we can see is that antibiotics use was prevalent in 60.4% of the patients. 2 or 3 patients started on an empirical antibiotic. 1/3 did not have fever or increase of white cell count, but even that, they received antibiotics. By the 5th day of therapy, 6% of therapy was unchanged, and 21.5% of the patients were de-escalated. This is really important because this percentage of de-escalation is really low, and the most important is more likely since the beginning, because after 72 hours we need to do adjustment. The most important is to try to do de-escalation with that kind of patient. So I was talking about COVID and antimicrobial resistance, and well, right now it's a problem. As I mentioned before, 90% of the patients with COVID-19 are receiving antibiotics. We are talking right now about how COVID-19 is accelerating the trend of antimicrobial resistance. World Health Organization is told us to take in conscious about this, because we are going to have, and we are accelerating the trend of antimicrobial resistance. These are the guidelines that the American Infectious Diseases update on 2018, and these are things really important that we need to do from the microbiology lab. And the first one is specimens of poor quality should be rejected. That's really important because sometimes, for example, we process saliva instead of a very good sample from the low respiratory tract, for example. Physicians should not demand that the laboratory report everything that grows. I think that's a main problem, and physicians should be aware that you don't have to do this. It's a bad practice, so please don't do that. Specimens from sites such as a lower respiratory tract sputum, nasal sinuses, superficial wounds, fistula, and other require care in the collection and the appropriate collection. Otherwise, we are going to treat colonization instead of a real infection. The laboratory requires a specimen, not a swab or of a specimen. Especially for wounds, it's really important to have tissue instead of swabs. A specimen should be collected prior to administration of antibiotics. Susceptibility testing should be done only on clinically significant isolates, not in all microorganisms recovered in culture. And specimens must be labeled accurately and completely so the interpretations or results be reliable. Really important right now to have this very good communication in the microbiology lab and the physicians, because sometimes they need to do decisions together, and sometimes the microbiology lab needs to know the diagnostic of the patient so they can contribute or help to the physician the best test for that kind of patient in order to resolve the infection. So this is a model about how do we have to do the antimicrobial stewardship program. And it's really important to have this interdisciplinary staff. That is really important. The microbiology lab, the infectious diseases, the epidemiologists, the pharmacists, the nurses, and all the chiefs of every ward or every service to engage in these antimicrobial stewardship programs, because they will have to do guidelines for empiric therapy. They will have to do guidelines to prescribe antibiotics for the most important infections. So it's really important that they work together. And of course, we are talking about diagnosis in the AMS program, and this is another publication from the group of Wellcome Trust for diagnosis strategy for better targeted antibiotics. They point about the rapid diagnostic importance, and we should have, in many times, rapid diagnostic as a point of care. Sometimes, for example, having diagnostics in the emergency room will change the prognostic and the outcome of the patient. So sometimes for some diseases, it's important to have this kind of diagnostics on the point of care. Avoid failure to treat by pathogen, for example, confirmed by culture after, but for the we are going to do a better treatment if we have diagnostic rapid diagnosis. This is an example of a journey from a patient and all the AMS interventions. So, for example, arrives to the emergency room, a patient acquire pneumonia, and you will have to decide if these patients have any risk factors to have a multi-drug resistant colonization before. Maybe it was a patient from dialysis or a patient with chemo. You need to decide which is the best empiric treatment. And here we have all the key decision makers. Maybe it will be the ER doctor or the ID specialist, the critical care physician. Then they need diagnostic to do a better target therapy, maybe resistance profile. And at the end, then you are going to change your treatment, and you are going to have to analyze the length of stay, how much does the result come back to you, the cost, which test did you use, etc., etc. So it's a very complete journey of the patients right to the hospital. So how are rapid diagnostic tests helping infectious diseases? You can see here one study where they use rapid diagnostic tests in patients with chemotherapy, and you can see the results. The important is that the patient was impacted on mortality, less mortality, better compliance with advice, and the infectious disease advice, and the physicians change the therapy. Impact on escalation and escalation, impact in length of stay, and impact in isolation. Remember, for ward of hematology patients, where you have, for example, an outbreak of flu or an outbreak of RSV or an outbreak of Klebsiella carbapenemase production, you will have to isolate that kind of patients and avoid an outbreak in your ward. So we need to take cultures. More or less 80% of the cultures became negative usually, but the total process requires 2 or 3 days, and those are 2 or 3 days that maybe we are going to have the right or the wrong therapy to the patient. So one thing that is really important right now that everybody is fighting is the Enterobacteria carbapenem resistance. So here is a map from all the world, and you can see all the carbapenemase that we have circulating in all around the world. And this is the study from Latin America, from Dr. Maria Villegas and her group. And we can see that in all Latin America, we have already the distribution of these carbapenemates. And you can see here Caribbean, and also you have most prevalent of metallobeta-lactamase. That is a real problem right now. So it's really important for us to be able to recognize the resistant genes or the markers of resistance that we are having in every of our countries. So for that, have became a lot of emerging technologies for rapid identification in bloodstream pathogens, in pneumonia pathogens, for example. So here you can see a lot of technologies. One of these is the Malditov or the mass spectrum, identification with molecular biology, like expert, film array, Virgin. I mean, we have a lot of new technologies based on molecular biology or PCR to try to identify directly from a positive blood culture the markers of resistance that we have in our bacteria in order to get better treatment sensitivity. So here you have the advance in molecular diagnostic tests for pneumonia. You can see we have next generation sequencing, the Malditov, the film array, PCR, and a lot of techniques, immunoassays right now to identify also carbapenemase. And here you have a lot of examples of molecular tests for pneumonia. We have here that the most important is the time that you have the results, and the most important that you can have results direct from a sample. That's the most important. Study about how these rapid diagnostics impact in the outcomes of the patient. So, for example, in this study, they used Malditov and the BCID panel from film array, that is the blood identification culture PCR multiplex. You can see that in the arm where they do the intervention, you can see the time to de-escalation is less when you have this kind of technology, when you compare to traditional methods like culture. So it's really important to point that this kind of diagnostics decrease the long stay, decrease the number of days that we provide antibiotics like combination therapy or anti-pseudomonal beta-lactams therapy or carbapenems therapy. So this is the most important. You can reduce like more or less 1 day at least of all these therapies when you use rapid diagnosis. Okay, sorry. Do you remember the patient? Remember, it was a patient with acquired ventilator pneumonia. In this case, the patient was started with meropenem 1 gram every 8 hours and vancomycin 1 gram twice a day. They request a PCR multiplex pneumonia panel and cultures. Remember the X-ray chest. And here is the result of the PCR multiplex pneumonia panel that they performed. So you can see they performed the panel for endotracheal aspiration, and the result was Acinetobacter baumannii 10 to 7 copies per milliliter, Klebsiella pneumoniae 10 to 6 copies per milliliter, Pseudomonas aeruginosa 10 to 6 copies to 7 copies per milliliter, and the worst thing was the markers for the antimicrobial resistance genes that all these bacteria had in this patient. We found a CTXM detected, IMP detected, and a BIM detected. So this is the last pool, and I would like to know which treatment would you use to treat all these bacteria that were causing septic shock in this patient with COVID-19 in the ICU. You're going to see the pool again. So these are the options. What would be the definitive antibiotic treatment for this patient? Meropenem plus colistin plus digacycline, ceftazidime bivactam plus astronam, ceftolozano tazobactam, meropenem plus amikacina. Okay, I think the floor pronounced. And yes, they will use meropenem, colistin, and tigecycline. That's what we gave to the patient. It's really important to know since the beginning, and I can tell you that for this patient, the result came 2 hours later than the turnaround time. The result was 2 hours after we took the endotracheal aspiration. And it's really important to have this result because otherwise, remember that we were treating the patient with meropenem and vancomycin. And of course, if this patient had to wait to the result of the culture, I'm pretty sure the patient had died in that time. You can see the results of the cultures, and we could isolate the Pseudomonas aeruginosa. You can see the profiles of the patterns of susceptibility. Of course, it was almost multi-drug resistance, only susceptible to tobramycin. And here you can see Acinetobacter baumannii also was almost multi-drug resistant, susceptible to tigecycline. So imagine that 72 hours after this result, had died. Other thing that is really important is that we need to be able in our hospitals and in our microbiology labs to know which is the marker of resistance that we have in our bacteria. So one antibiogram, you are only going to see resistant to meropenem and resistant to meropenem or resistant to imipenem or even resistant to ertapenem for enterobacterials, means all of this. And I love this table because it's really visual. You can see here that carbapenem resistance implies not enzymatic resistance, enzymatic resistance. The non-enzymatic, we can have mutations in porins with impermeability. We can have efflux systems, and we can have enzymatic resistance markers like serine carbapenemase or metallobeta-lactamase. So it's really important to know, for us right now, to know which is the marker who is responsible of the resistance. Here are the new antibiotics that are coming in Latin America, in the most of the countries. We already have ceftolozane tazobactam or ceftazidime bivactam. So it's really important to know, to us, to know if it's a metallobeta-lactamase or a serine carbapenemase, or maybe it's an efflux bomb or other mechanisms of resistance. Otherwise, we are not going to prescribe correctly this kind of antibiotic. So, a couple of studies showing the importance of having this antimicrobial stewardship with these new technologies. If we don't have an antimicrobial stewardship or a team that supports the physicians to better prescribe antibiotics, we are not going to have results even we have the best technology. So this is a study that was done in the Mayo Clinic, and you can see that they implement the detection of all the patients with positive blood cultures or bloodstream infection. And they use the BCID panel for PRIMA-Array and ASP program. Actually, they hire people to do the ASP program. And what you can see here in this study is that in the arm that they use the PCR multiplex test plus the stewardship, you can have faster time to appropriate the escalation, fastest time to appropriate the escalation, decrease of unnecessary use of vancomycin, decrease of duration of piperacillin tazobactam therapy, and more contaminated blood cultures were not treated in less than 34 hours. Actually, the patients could go home with the result of contamination, the blood culture like staph epidermidis or a staph coagulase negative. So it's really important to have the antimicrobial stewardship programs. And also, as I mentioned before, the biomarkers like procalcitonin helps to do less antibiotics in all the patients. This is a study with patients with pneumonia that arrive to hospital. And in this kind of patients, what you can see is the arm that they use an algorithm with procalcitonin. The patients receive less antibiotic than the patients that did not use the algorithm of procalcitonin. So my key messages for you are the antimicrobial stewardship are necessary in all our hospitals, and we all together have to push to have these kind of programs. Results need to be rapid within a time frame that impact therapeutic decisions or in a time frame that affects clinical outcomes. Results need to be comprehensive. I mean, we need to differentiate versus virus, bacterials, or atypical bacterials or fungal. Results need to assist in interpretation of colonization versus infection, and interventions need to be involved with the antimicrobial stewardship team for benefits. This is the most important. So thank you very much. Muchas gracias. Please take care and be safe. And remember, wash your hands and don't spread germs. Thank you so much.
Thank you very much, Dr. Norma, for this wonderful and clear presentation. I would like to remember the participants that they can type their question in the chat box, and I will do the question for them. I will start with a couple of questions to you, Dr. Norma.
Yes.
At the beginning, you asked in the post, who have an antimicrobial stewardship program implemented in the hospital? As you saw, none of our island have this in place. From your experience, how you recommend us to start little by little with this important antimicrobial stewardship program?
Yes, it's really important to begin with little steps. Otherwise, you have a lot of frustration and maybe you are not going to be able to have results. So even you don't have, for example, an IT physician or epidemiologist, you will have to have first a physician in charge of this kind of program. It could be a physician or maybe a nurse that have a lot of experience in epidemiology, or maybe a pharmacist, if you have pharmacists in the Caribbean. Maybe you can start with choosing who is going to be the person in charge of this AMS program. The second one thing, and is really important, and all the guidelines point to this, to have the support from the directors or the managers from the hospitals, the medical managers and the finance managers, because they will have to provide support to start this program. And maybe another thing that you can do, also, you have to be involved in the microbiology lab in these kind of programs. The microbiology lab is really important because they will have to provide more or less every 3 or every 6 months the surveillance data from the hospital. Because with that little things, for example, the surveillance with the prevalence of the most important microorganisms and patterns of susceptibility, you will be able to start guidelines. So maybe you can start with 2 PI indicators or with 1 indicator, and maybe you will have guidelines of how to treat nosocomial infections regarding your epidemiological data, and maybe you can choose another indicator like prophylaxis in surgery. We have to remember that in surgery, we usually use the prophylaxis like 7 days. That is not a prophylaxis, that is a complete treatment. So maybe you can start to doing adjustment in prophylaxis surgery. So the most important will be the surveillance data and the guidelines to the most common infections that you have in the hospital. That could be a couple of things easy to implement and that can give you results in your hospital to start an AMS. And also another thing I think help to start an antimicrobial stewardship, have someone that review every day all the prescription of broad spectrum antibiotics like meropenem, vancomycin, tigecycline, colistin, for example, should be a very good options of antibiotics that you can measure and you can review every 24 hours in order to see if the patient really needs that kind of antibiotic. Oh, cephalosporins of third generation, for example, ceftriaxone is also another antibiotic that you can measure, because remember that those kind of antibiotics are the antibiotics that produce more selection of multi-drug resistant bacteria. So maybe you can start with that.
Thank you. We got a question from Rowan Edward. If you can repeat the departments that must be involved in the creation of the Antimicrobial Stewardship Program.
Yeah, okay. It has to be microbiology lab, of course. Nurse, because it's really important to have the nurse. The nurses are always involved in all the patients, so maybe they can help to do the rounds. One epidemiologist or an infectious disease, or if you have both, it's perfect. Otherwise, you can have an internal medicine that can have some studies in antimicrobial stewardship. It's a good option. You have to have the medical director in order to support the program, and it's better to have the manager or the chief of the ICU or all the critical areas, at least in these antimicrobial stewardship programs. Oh, and the pharmacists, if you have pharmacists.
Clear. I have another question coming in from Benedicto Rojas. What policy or standards can be implemented to avoid the antimicrobial resistance in intra-hospital?
Sorry, again, can you repeat?
What policy or standards can be implemented to avoid the antimicrobial resistance intra-hospital?
Okay. Here, that's a difficult question, and you will have to sit with your physicians and with your committee to talk about this, because there are different interventions that you can do. For example, the first one is formulary restriction. I think that's an important thing that works in the hospitals. So you will have to require a formulary to prescribe these special antibiotics. The antibiotics that are from broad spectrum and that are used to treat multi-drug resistance organisms. So someone needs to sign in order to prescribe that antibiotic. So that's the first one. The other one is intervention that you do an assessment every 24 hours. If someone prescribes one of these antibiotics. Those two are the most important things that you can implement in the hospital to reduce the antimicrobial resistance. It's a very important point that for you to diminish the resistance, the antimicrobial resistance in one hospital, after you implement an antimicrobial stewardship, it will take more or less 2 years to diminish this antimicrobial resistance. So don't put it as a primary indicator, because really it's going to be very frustrating. So try to do a long-term revision of all the patterns of susceptibility of your bacteria, more or less like 2 or 3 years, before you can see diminish of the the resistance of your organisms in your body.
Thank you. I have a follow-up question from Mr. Nelson. How often should an antibiogram be done?
The cumulative antibiogram, it will depend, but usually at least you will have to do one a year, at least. The better practices is having every 3 months or every 6 months. But at least you will have your cumulative antibiogram once a year. And it's important to show it to all the physicians of the hospital, so all the physicians are aware of how is the hospital doing in order of the microorganisms.
I want to ask you this question, Dr. Norma.
Yes.
As you eloquently stated in your presentation, is diagnostic antimicrobial stewardship next to a well-implemented antimicrobial stewardship program very important. The example that you use in your presentation show us this, but as you should know, we from this island have to source out many of our materials. So we are small islands, small laboratory, and don't have all the equipments in place to do rapid diagnostic. How do you recommend us to deal with this? And
yeah,
most of the island have a lot of COVID patients also. So how you recommend us to deal as small islander with this?
Now, this is an important question, and actually it's really interesting to see how these equipments of multiplex PCR that are little equipments that you can use even out of the microbiology lab sometimes, helps to identify some markers are resistant, and even you don't have a big molecular laboratory, biology molecular laboratory or a big laboratory, you can use this kind of technology. It's an important study in Australia, in a very long town in Australia where only they can arrive in helicopter, that they implement this point of care PCR multiplex diagnostic test. They could have a better diagnostic and a better approach to these drug organisms, resistant organisms. Well, sometimes it helps because you can implement it wherever you are. So it could be a good help in the islands to have this kind of equipment, even you don't have a very big laboratories of microbiology. But I mean, we still using manual or sensitive or in test or these kind of things that help us to fight resistance. So, yes, it's a difficult question, but there is always an option, I think.
Thank you. I have a last question from Mr. Rojas. Do you think antibiotic stewardship should be standardized in region or per hospital?
Oh, it's a really interesting question. It has to be by hospital, because every hospital behaves different, and every hospital has a different patterns of susceptibility or to resistance. So it's really important to have the surveillance data from your hospital, and the antimicrobial stewardship has to be implemented in your hospital. And of course, it's important to have a national surveillance network and know what is going on in your country or in your island. But the most important thing is to have the knowledge of your hospital and implement according to your hospital.
I don't know if there are more questions. I don't see more questions. If there are no more, oh, yes, one more. Renee Lawrence. We have like 4 or 5 laboratories on the island. This is some problem to start this program? That's the question. So
yeah,
on this island, there is 4 or 5 laboratories, and he asked if it is some problem to start this program, antimicrobial stewardship program.
Yeah, I know, but maybe, I mean, you can start from every laboratory. It's interesting that we have in Mexico, we are starting to work with some laboratories to do an antimicrobial stewardship of well, for a surveillance vigilance of what's going on in the community bacteria, because it's important to know what is going on in the community. So even you are one laboratory, maybe you can start with your own data and start little by little, as I mentioned before.
Okay, I don't see more great presentation. No, I don't see more questions. Before I thank Dr. Norma, I would like to remind all the participants to complete their survey that will appear at the end of the webinar by clicking on the link. So please complete the survey in order to get your free certificate. Dr. Norma, I want to thank you very, very much for this presentation. It was very clear, and it was an honor to have you in our cast for the first time for all the Caribbean islands. Dr. Norma is a friend of us, and she knows a couple of laboratories in the Caribbean by virtually assist us with the lecture. So Norma, Dr. Norma, I hope after this Corona crisis, we can welcome you in the Caribbean. Thank you very much.
No, thanks to you, Emelie. I'm honored to be here, and thanks to all of you and for all your questions. Yes, hopefully we can see on live soon. Please take care. Thank you.
Bye-bye.